Well, an amazing fact is that we have finished the reports from the breakouts at nearly the exact time that we said that we would, and in fact it's a little bit early. So we have time for discussion. And what we were hoping to be able to do at this point would be to actually be able to discuss the reports that we've heard. We're not bringing the rapporteurs back up, but honestly, if you have any questions about any of the reports that you heard, or if there are questions that you think that are missing, or if you've heard topics that you think are deserving of immediate attention, that you want to focus more attention on those, this is a time to do that. And actually, in terms of the people controlling the light in the room, we could have a little more light, I think, in the audience, because we're not going to have more PowerPoint slides. Yes, we'll start here.
Thank you. Mike Ostrom, University of Minnesota. One of the things I'm continued to be struck by is the lack of precision in our terminology and understanding of aerobiology. And here in this meeting, I heard a number of presentations that talked about airborne, which technically is a term that should be done away with, because in fact it's not completely accurate in terms of what we're talking about. We surely are talking about droplets, and we're talking about aerosols, and we're talking about aerosols where you may have viable agents in that aerosol, you may not. I've worked up outbreaks where I've seen measles virus transmitted from somebody standing at home plate to somebody in far right field, a whole cluster of people up there. That's one kind of transmission we're talking about. And I think what's happened is part of this risk communication is in the community there's been a great deal of confusion between aerosol and droplet production in the patient area and that of actually talking about it as a potential measles-like, influenza-like transmission, which is also an aerosol. And I think we don't do really any help here by not being more precise about our own understanding of aerobiology. And I know as somebody who surely would not proclaim to have expertise in that area, I've had to learn a lot from the aerobiologist, and you actually had one here today who gave such a presentation. I hope this report can accurately reflect the state of the art of aerobiology and help us to get away from that so that we can actually start talking about what we really are concerned about in either the patient area, the immediate patient area, or in a larger range area, which today we have no evidence that that is an issue. And I think that would be a very important step forward, because if we have the president saying this is not airborne, what does he mean? Or if we have people in our federal agency saying this is not airborne, yet we're concerned in that immediate patient area, that is not an accurate way, and that's where I think the public's getting confused. I think our colleagues are getting confused. Why worry about wearing an N95 if this is not airborne and only droplet? And so we've created our own problem here, and this would be, I think, a good first step to start to basically change that and help people understand the dynamics of distance, the dynamics of size, and the dynamics of viability. That's what it's all about. It's not just about a terminology.
So if I may, Mike, I was surprised in the reports back that I didn't hear anybody propose that research be done where we would actually go and take measurements in Ebola treatment centers to see, if there are aerosols, droplets that contain the virus. Because I do think that you're making a valid point, and this is a researchable question, even though I would guess it would be extraordinarily complex to make those measurements, dealing with a BSL-4 agent. But yet I know that we have robots that are planning, that are being designed to take samples on Mars to bring things back here. And I can't help but think there must be some way of doing this. I don't know who would be tasked with doing it. But it's simply, nobody proposed it. And perhaps because it just seems like it would be too daunting technically. But it would be helpful to have actual information on that.
And if I could just add one other piece, I think that was not really here, it was implied in several of them, but we really need to know much more about the genomics of this agent. Both the genotype and phenotype issues, what drives it, what is the current environmental conditions that might drive phenotype immersion out of this whole thing. And I think that that's really a key piece. The fact that we are this far into this outbreak with so little information really begs the question. And I know how difficult it is in being in West Africa, and there are people here who have been on the front lines and can say, there are many, many challenges, and I surely don't want to minimize that, but I think this is really important for us to have that kind of information, and however we can help to collect that in the groups that do that.
So earlier in the day, somebody raised the issue of sharing, sample sharing, making samples available,
Right.
and I saw a lot of body language that indicated to me that for some reason that's been extraordinarily difficult
Right.
in this
Yeah,
particular situation. But nonetheless, what you're suggesting could only be done if it were possible for people who can sequence the virus to obtain it, right?
Thank you.
Next.
Yes, hello, Marianne D'Alessandro with NIOSH and PPTL. I'd just like to comment on the supply chain issue that was raised in the PPE session and talk about some of the things that we're doing and how that could be leveraged to take it a little further. So after H1N1 with the respirator supply issues, we started looking at existing surveillance systems to determine how we could leverage those systems to gather PPE information, to try to roll out the PPE to the hospitals that needed it when there were shortages and additional needs. And we found that there weren't any systems that we could tap into at the time. So what we did is start a pilot system to gather respirator data within the healthcare system, and we had a contract that was issued to Vanderbilt University to explore these types of issues with 4 hospital systems. So the system has been rolled out, was piloted at Vanderbilt, and now they collect all kinds of data relative to respirator use and how the respirators were used, purchasing information, what departments need them, respirator use in emergency situations, and all of that has also been rolled out now to Emory University, Cleveland Clinic, and Duke University. And several weeks ago, when there was a flurry of activity and a need to see what PPE was in various locations, we were able to gather the respirator information in those 4 systems in a few hours. So what we're trying to do is seeing how we can leverage this to gather other PPE information in these 4 systems, and then how we may be able to roll it out to the 20 Ebola referral centers in the same way that we have in these 4 systems. And this could be a PPE surveillance system that could help inform the nation when PPE needs were, when you needed to act upon what PPE needs were out there, so we don't have this urgency that we have now and the activity that we have and not getting PPE to the right places when it needs to get there. Okay. Thanks.
Penny Hitchcock. The elephant in the room for me is how much this is going to cost and where this money is going to come from. And I think that quickly we ought to get the World Bank and other agencies such as that, maybe even the Federal Reserve, because if we cannot get our arms around this, it is going to destroy our economy and everyone else's. So this is a national, if not international, emergency, and there is no money, not the kind of money that we're talking about. So as we can help as scientists to help you document the seriousness of this and what it's going to cost, I'm sure we're all here to help in whatever way we can.
Thank you. I know that Dr. Kim is very much thinking along that line of what you just mentioned. You really need the kind of financing for this to happen. Thank you.
I'm Michael Hodgson, currently OSHA, but speaking here on this now with a different hat. Over the last 25 years, have worked with ASHRAE, the American Society of Heating, Refrigerating, and Air Conditioning Engineers, and wanted to follow up on a comment of Dr. Osterholm's. It is important to distinguish between, as we in the U.S. do, large and small aerosols. But from a physics perspective, that's a very artificial distinction. And in fact, Dr. Milton, who I think was standing behind me for a minute, and I don't know whether he's going to talk about this, 10 years ago published in the New England Journal that paper on facultative transmission, arguing that intellectual distinction between fine and large aerosol droplets was artificial and probably not realistic. And in fact, if you, the humbling pictures of the environment in Liberia, those 2 pictures of a tent and an open space for a hospital, remind that air exchange rates in Liberia are probably orders of magnitude larger than they are here in the U.S. So where we think of an air exchange rate here of, 1 or 2 in your usual building and in an airborne infection isolation room of maybe 6 to 12, I'll bet you each of those buildings had an air exchange rate in that higher range. And so there are some hazards to sampling and to extrapolating data from a country such as Liberia to what we would encounter here. So as we design experiments and as we think about extrapolating our knowledge to other countries and taking knowledge from those countries to our home, we should be very careful.
Jeff Duchin. Lynn, I just wanted to clarify that I didn't want there to be a misimpression about what we had recommended, and maybe it didn't come across, but our group did prioritize the question of does infectivity vary with different tissue sources and routes of exposure, and implied in that also would be aerosol as a potential route of exposure. I also wanted to mention that there was something in the parking lot that I think deserves mention among the other good suggestions that you'll find in the parking lot, but Stephen Phillips suggested that someone put together a meta-analysis, a meta-review or a synthesis of existing literature about what we know of Ebola virus from past outbreaks, genomics, and other sources, so that it would be able to be found in one place for those who are trying to find currently, where the best information is, and instead of having to sort of search through a variety of sometimes hard to find older literature.
Thank you.
I identified earlier, but I'm still Somasundran at Columbia University. Two topics, I don't know whether I missed it. If I missed it, stop me. One is identification. I saw a senator on the TV the other day. All he had to do is measure temperature. So I fired a letter to the New York Times. Doesn't he know about Tylenol, aspirin? If I want to get back home, all I had to do is take some of it. They liked it. They published it the next day. So what is there another way to identify, detect, than using blood, which is very hard to sample from everybody, something like a saliva-based? Long back, we developed a technique to detect the glucose from tear. So is that possible? It cannot be done overnight using some spectroscopy technique. That's one. Second is topic is mutation. I didn't hear anything about how soon it might mutate. Could it be airborne? And finally, I heard a comment about aerosol. Actually, even between fine and coarse, not only fine, there's a size distribution of aerosol, which will change as a function of time. It will evaporate. For example, cigarette smoke, I was involved in measuring the size distribution of cigarette smoke. It may be 0.5 microns in the beginning, and it evaporates, the liquid evaporates, comes down to 0.1. So the size distribution changing as a function of Liberia here, temperature is different, and so on.
Thank you.
Thank you.
Andy Pavia, University of Utah. We spent a lot of time thinking about what needs to be looked at in research, but I think we should also devote a fair amount of time to the timeliness of getting those answers and what the barriers are that stand in the way. And those are the ones we've identified in previous emergencies where we've tried to get answers quickly, and perhaps some new ones in this outbreak that involve the importation of samples. Sharing of data has already been mentioned, interoperability of data collection instruments, and I think that requires more than a few minutes thought.
Sure.
Dan Bausch from Tulane University. As we go forward with the discussion of the research program, much of this, as I said earlier, can really only be done at the patient interface in West Africa and to collect any data that's really interpretable. And what I see is, to some degree, two parallel processes that I think we need to make sure they come together, because as the DoD and PHS program goes forward to set up these treatment centers in West Africa, we're going to be heavily reliant on those treatment centers. That's where the patients, that's where the samples, that's where the data need to come from. And of course, we're not going to be able to have two completely parallel systems. There's not going to be one research ward and one treatment ward. It's all going to have to, at some point, interface. So I think we need to make sure on some level, and I'm not sure exactly what that level is, but on some levels, we have crosstalk to make sure that there's integration there. Thank you.
Thank you.
I just wanted to expand on Dan's comments there, I guess maybe one final comment, which is the need to basically blend the research opportunities, both in terms of clinical research the experimental or laboratory-based research, and as well as the field research, and to do it smartly. So if we do have at the Monrovia facility, and we're going to be doing clinical samples on individuals, we should then also try to obtain environmental samples as well that match, and try to do experimental work that supports and mimics, both in terms of identifying sampling methods and approaches that can be exported to the field, and vice versa. So I think the challenges and opportunities, the challenge is bringing together those different parts of the workforce and research community to contribute to this, and the opportunity is certainly presenting itself in this new treatment facility, as well as other areas if we continue to have cases here in the U.S.
Aubrey, can I ask you a question? One of the activities that I heard that you are involved with is with the National Library of Medicine pulling together a lot of the literature on Ebola. And is that available? What are you going to do with that?
Yeah, so the NLM has been putting out a page of available literature. So as we started looking at these environmental issues, they started pulling those together and making those available. So that's publicly accessible. I don't have the link information. We can get that to you. You can include it as well. But it should be hosted right on the NLM webpage, which they actually just ping Ebola, I guess, on NLM's website, and that should bring it up.
Great, and we'll make it available through our report as well. It's a great resource. Oh, look who's here.
Well,
hello.
Well, thank you, yes. We have about 300 references now related to Ebola. We're aiming at doing this meta-analysis and at least having one central portal where people can go to and be referred to, so on and so forth. I think the lessons learned would be very valuable to all of us.
Well, and in preparing for this meeting, I noticed that a lot of the references are pre-PubMed, so that's really helpful that you're able to pull together the older literature. Because
and aside from PubMed, there's a group of gray literature we're calling the disaster literature, which is authoritative information, but not in peer-reviewed journals. Most of these are after-action reports, Red Cross reports, anecdotes, and so forth, and we're really trying to organize that into a PubMed type of format so that it would be available for use.
So if people in the room have literature like that, do you want them to just contact you?
Absolutely.
Okay.
We'd like to be just like the genome in a way. All the information comes into us, it's organized, verified, and made available open source.
Great.
Thanks.
Dan Fabui, Children's National Medical Center at George Washington University, and I'm here actually representing the American Academy of Pediatrics. So I always have to put my kid's hat. I'm an emergency physician, formerly served on the National Biodefense Science Board. As with children, there are always ethical issues that involve research. I think it's important to make sure we mention that and don't leave them behind. And the reason being because most of our medical countermeasures, when we start thinking about this, becomes an issue. So it'll be good that children are included in the research, and do not let the ethical issues preclude research on children. We have some work that has already been done. I was the chair of the anthrax vaccine work group, which was a little bit controversial, but it was a document we did publish. And we also had our Presidential Ethical Committee review that. They made some recommendations. Of course, now that was 6-8 months ago when anthrax was considered not a threat by some, and in this case, plug in Ebola, a threat. It's not imminent anymore, it's actually happening. So you can use that also as something to leverage the discussion. Thank you.
Thank you.
Dan, if I may, are there mental health issues that are involved with this in terms of risk communication and how children are hearing about this and the messages that they're receiving about this?
Great point. Yes, there are. There are many. Many of my colleagues have looked at this. The Academy is looking at this, and many who have dealt with mental health issues, from the Sandy Hook shootings to any number of issues. Yes, kids have been talking about Ebola. Even my kids have been talking about it. And the question is how you have that communication with them. Areas of research that haven't been looked at is actually people in PPE coming towards children. How does that impact them from a medical or from a mental health issue? It's almost like the marshmallow man or women approaching them. Nobody's really looked at that, so that's an area ripe for investigation also.
hey, my daughter used to be afraid of a guy in a clown suit, so, you know.
Okay.
Right. Are there any further comments? If not, I think that perhaps we can bring this to a close.
Cool.
Dr. Zhao, do you want to?